started?
Just for a second, sir. We are going live on YouTube.
Already you are live, no? It's there.
Live on YouTube, sir.
No, it takes a time till we start streaming to the YouTube. I have to do a couple of steps. So, okay, hello everyone. Welcome to one more lecture. Today is a very important lecture of our OrthoPG series. So, without any delay, let me request Dr. Prashant Agarwal to introduce today's speaker, and then we will go ahead with the presentation. Dr. Prashant, sir.
Yeah. This is a Apollo Orthopedic Home Lecture Series, and today's topic is shoulder examination by our colleague Dr. Vikram Paode. He does not need any introduction as such because he is senior consultant at Apollo Hospital, Navi Mumbai. Before Apollo Hospital, Navi Mumbai, he was in Scotland for quite some time, and from there he has come and joined Apollo Hospital, and he is giving his services here. And he is a very active member in our postgraduate teaching program. So now I welcome Dr. Vikram Paode and request him to start his lecture. Dr. Vikram.
Thanks, Agnivesh, and thanks, Prashant, for this rather very generous introduction. It just happens I have happened to do a little bit of orthopedics and I've been given this opportunity. So without much ado, we'll start with our presentation. Hopefully, it will be helpful. Share. Just a moment, please. Share. Okay, can everybody see the slides, please?
Yes, we can see and we can hear you, sir.
Okay. So shoulder examination in this new DNB format will be most probably as a short case. And although I would have loved to go by a standard structured format like look, feel, see, and move, and giving a periodic test one after another, I recently happened to be in a national level examination as an external examiner. And what I realized is the real time given for you guys means the student is only 10 minutes. And it is an examiner driven exam. So with that in mind, I would first present 2-3 common cases and then a structured teaching program, which is expected of a shoulder. So please bear with me. Now, first of all, it is important for us to remember what exactly shoulder is. It is a suspension of the upper limb. No wonder the common question in the fellowship examiners, what is the suspensory mechanism of the shoulder? And it acts as a fulcrum for arm elevation. Now, as you would have imagined, shoulder is not just a joint, glenohumeral joint. We have to think about all the structures which are suspended with it. It starts from scapulothoracic articulation, glenohumeral articulation, acromoclavicular joint, and the sternoclavicular joint, of which sternoclavicular joint is attached to the main skeleton of the body. Rest of all, it is floating. How the shoulder movements happen, which ligaments control which movements, we will see on a case-by-case merit when we discuss each of the individual case. This is just to tell you about the anatomy of the shoulder. The first case which we are going to discuss would be most commonly instability. I will be most surprised if you will get a dislocation or a subluxation, and laxity. So the case you guys are likely to get in the exam is an instability or laxity. We know all about the definitions. Instability is inability to maintain the humeral head in the glenoid fossa, including a spectrum of dislocation, including a habitual dislocation. This could be a collagen type of fibers deficiency. Dislocation is traumatic. Subluxation could be because of repeated dislocation and loss of the soft tissue structure. Now, the shoulder, as you can imagine, is made up of labral lesion, that is a soft tissue, Bankart's, capsular instability. We'll discuss HAGL with an arthrogram later on, and bone loss. In this exam, it is only not the clinical examination which the examiner will be asking you. He might show you an X-ray, an MRI, he will like to know your plan, and he will decide whether you are a safe surgeon or not. So this is a classical bony lesion which we see in the shoulder. I got a young adult male, 28 years old, a previous bank cards done somewhere. You could see these are the bony, you could see the metallic anchors in the glenoid. The glenoid is inverted pear-shaped. There is a bony Bankart lesion. Now look on the right side to the humerus and you could see the big Hill-Sachs lesion. In X-ray, it looks more draconian. It looks exactly like a W trough. How do you fix a glenoid lesion which is more than 25%? I would rather go for Latarjet because I'm not a great fan of glenoid osteotomy. So if you notice, the coracoid has been chipped off and has been fixed with the 2 screws to the glenoid, and he's doing very well. So this is in all nutshell about a bony lesion in a shoulder dislocation laxity. This is the X-ray, which shows that there is such a massive Hill-Sachs lesion. It is forming a W trough, and this is where we have done the Latarjet procedure with the screws, and the previous anchors have been removed. Just to know about the anatomy, shoulder joint enjoys its mobility at the cost of stability. This diameter of the glenoid is 41, including the diameter constructed by the labrum. So as such, there is a tremendous mismatch between the glenoid and the ball of the shoulder. It is classically described as golf ball and tee, very mobile, hence instability. It accounts for 45% of all dislocations, and joint stability depends on multiple factors, as we know. It's a humeral head. We have discussed how humeral head angle of 130 to 135 degree and 30 to 40 degrees is retroverted in the femoral plane. Long head of the biceps is also stabilizer, and all the ligaments which will assess on each case. You can see the conoid and trapezoid ligament. They help in the vertical stability, and look closely the blue colored superior, medial and inferior glenohumeral ligament. These ligaments we never paid much attention, but with the advent of arthroscopy, we are getting into it and we realize how important especially the medial and the inferior glenohumeral ligament is. Now this will be the case, a boy, a young lad sitting over you, and you students might go with an idea that I will go and start inspection from the front, from the back. I will examine each and every individual muscle. And then I will do the impingement test and this test in a one particular sequence. But the chances are, examiner, as soon as you mention, see all those scars of the revision Bankart, even the revision Bankart in this case I have done with arthroscope only. After just you start mentioning scar, the examiner will just stop you there and ask you, okay, doctor, he has got an instability. He has got a dislocation. What particular test you would like to do for that case? So you can still mention that there is a wasting of the muscles. There are the scars. This is the anterior portal. This is the posterior portal. And the posterior portal is for the remplissage procedure. First start with is the Hawkins test. You take the arm to the opposite shoulder. Then the most important test the examiner will like is an apprehension test. You can do it in the upright position, but I would rather recommend you do it in the lying down position with the scapula supported on the table and the head lying out. You rotate it to 90 degrees, which we'll see in the next clip, and put the thumb on the ball of the head and try to dislocate. You will not get any marks for dislocating the shoulder, but the moment the patient winces his face or he becomes apprehensive or muscle goes guarded, you have to stop there and there only. So for the sake of clarity, we have done apprehension test in a standing position, and we will just now see. So see, Akash is trying to put his thumb on the ball of the shoulder and he's going into external rotation. This is the same guy which we had done the reverse revision Bankart with remplissage. He's an IT engineer and he's a mountain climber, and he's so happy that he is allowing us to do the apprehension test. So this is the test which is the most important. One more thing I would suggest is you must check for the laxity of the fingers, because more often than not, these guys might have laxity 1+, 2+, and that is perfectly normal. Jobs relocation test, or you can, what is a variant is anterior and the posterior drawer test. Keep the patient supine, rotate the forearm, pain and apprehension appears first, press down on the arm and shoulder, it releases the pain or the apprehension. So this is another variant for checking the relocation test. Look carefully into this X-ray. Same guy, revision Bankart. The first Bankart has got metallic anchors. This time we are used biodegradable anchor. You could easily see the Hill-Sachs lesion. You see on the outer aspect of the shoulder, there is a shallow. But that is not the point I'm trying to draw your attention to. What I'm trying to draw your attention to you in this immediate post-op X-ray is the sulcus sign. What exactly is the sulcus sign? You will find it when there is a muscle wasting, there is an inferior capsule laxity, and the patient has been immobilized for n number of duration. So you will find it in a hemiarthroplasty of the shoulder. Your junior resident might call you that, sir, I think post-op X-ray, the hemi looks subluxated. In this case also, we had similar problem because he was so apprehensive after the first operation, his arm was just slipping down. So this was the sulcus sign. This X-ray is immediate post-operative, and you have seen how nicely he's doing that even his apprehension test has become negative. So let's see how you perform a sulcus test. As I mentioned, it is for inferior capsular instability. Patient sitting, make the patient relax, flex the elbow to 90 degrees and give a downward tuck. Another hand always in shoulder, grip between acromion anterior and the posterior, and there is a frank sulcus which appears between the acromion process and the humerus head. This test might be of significance to some of the examiners. Next test which we are going to do is the O'Brien's test. O'Brien's test has got mention in the instability or sometimes in the slap tear also. Slap tear is a very American thing, but now their interest has also waned away. They have become wiser by their experiences. Generally to only young athletes, overhead athletes, complaining the posterior aspect of the acromion on the glenoid from 12 o'clock position to 9 o'clock position. What we are trying to do is trying to pull the biceps and the attached glenoid labrum at the superior position away from it. So let's see this test. So see, Akash is just holding it arm, pulling it up, doing an inward tuck and checking for it if there is any pain or any discomfort on the anterior or the posterior aspect of the shoulder. Classically, if you ask me for slap tear, Kuhnig's sign is very positive, and now the recommendations have changed. Of the 10 tests you perform, even if the 6 has to be positive, you start labeling patient as a slap. He's the same guy. One of the most common cause of failure of the revision Bankart is inability to identify the inferior humeral avulsion of the glenohumeral ligament. See, we have done the arthrogram in our hospital and see how much arthrogram is going into the axillary pouch and it is all open. We didn't realize why so much of the revision Bankarts were failing till remplissage pointed out that unless and until you do remplissage procedure for Hill-Sachs lesion, you will have 60 to 80% recurrence. Then the next step was humeral avulsion of glenohumeral ligament. Be very careful because axillary nerve is just over where the dye is leaking out. There have been instances where axillary nerve has been anchored into the humerus along with the soft tissue. That is the same bony Bankart lesion with an arthrogram. See, there is a big bone over there in the front of it, and it's a glad lesion. The dye is moving away in the front of the glenoid, which it should now. Look at the posterior aspect of the glenoid, there is no dye. So this is a glad type of lesion. So this is in all nutshell about the shoulder instability. You will be surprised, you will have only 10 minutes. Next case I would like you to consider is the acromioclavicular joint pathology. It will be very unusual for you to get a frank acromioclavicular joint subluxation. More often than not, you will find a young athlete, again an overhead athlete, who has got an acromioclavicular joint pathology and also biceps tendinitis. They generally go hand in hand. So let's go and see to that. This is a trauma case which we are presenting because it will things make very clear for you. Look at the clavicle, and it appears that there is a lateral end of the clavicle fracture. Then there is acromion. I'm sorry, somebody has not marked acromion properly. So see how much the clavicle has gone posteriorly and it is embedding into the trapezium. What appears is a broken end of the lateral end of the clavicle, and that is the case one would have think. In this case, always look from the posterior. Looking from the posterior is very important. Always mention there is a scar, there is a swelling, there is an inflammation, there is a wasting. And when we look from the back, we will discuss briefly about dyskinesis of the scapula as well. Now so you have made a diagnosis of the fracture of the lateral end of the clavicle, and now examiner pops up this X-ray for you. Look carefully, it is not the lateral end of the clavicle, but it is the proacromion and the mesoacromion which has fractured. Or in a simple English, you might say it is the terminal process of the acromion which has fractured. But why the clavicle is jumping so high? Generally, what should be the distance between the clavicle and the coracoid process? This means the conoid and the trapezoid ligament are also torn. Then we have just now seen in the ligament in which I have shown you all the glenohumeral ligament, there is a coracoacromion ligament. Before we used to think coracoacromion ligament is just a secondary stabilizer, and if you look into the Weaver-Dunn procedure, we used to transfer coracoacromion ligament to the lateral end of the clavicle. Not anymore. It is a very important structure. It prevents the superior translation of the humerus, just like biceps, and it equally prevents the inferior translation of the humerus as well. So it is not a secondary stabilizer, it is a main stabilizer. This is the same CT scan. Now, what is the function of conoid and trapezoid ligament? You must understand. They prevent the vertical translation of the clavicle. What is the function of coracoacromion ligament? It prevents the horizontal translation of acromion. Why this 3D reconstruction? Because it will help you understand when you rotate the arm, 40% of the movement of the clavicle are just transmitted by 10% to the acromioclavicular joint. So acromioclavicular joint is a big shock absorber in the shoulder girdle, which we never realized. We always thought cleidocranial diastasis, absence of clavicle, and we are doing fine. No, we need to reconsider our applied anatomy again. This is again an MRI arthrogram, but I think this will be too detailed for the guys. Generally, conoid and trapezoid ligament are best seen in the sagittal view, not in the cornal or the axial view, and we need a musculoskeletal radiologist or a talented orthopedic surgeon for that. If you have noticed, guys, I have mentioned X-rays, like in any other place, are very important. Now look into this glenohumeral joint. It looks perfectly fine. And if you look into that sulcus sign, the glenohumeral joint was very bizarre because scapula is at an angle of 30 degrees on the rib cage. It is not exactly parallel behind the rib cage. So what you need to do is you need to move your X-ray machine or the beam 30 degrees. Now this is the same case which we have discussed before. We have fixed the conoid and the trapezoid ligament by dog bone. If it is more than 3 weeks, I will reconstruct it with a semitendinosus tendon. And equally, I have done, can you see a black button on the lateral end of the acromion? Here I have done an acromoclavicular bracing. There is another anchor on the medial side of the clavicle and another anchor on the lateral end of the clavicle, so that the anteroposterior mobility of the clavicle is composed, and so is the vertical. He's a young guy, he's planning to join and is into very much of physical activities. So we need to be very careful and treat this patient with due respect. Now this is another fancy test. What is a Paxino's test? Thumb is placed under the posterolateral aspect of the acromion and the index and the middle finger of the same. Pressure on the acromion and the anterosuperior direction with the thumb. While at the same time, you're also applying pressure on the inferior direction to the mid clavicle with the index and the middle finger. Basically, we are palpating the acromioclavicular joint. If there is a pain, this means there is some pathology in the acromioclavicular joint. It could be arthritis, it could be fracture, it could be any type of dislocation as well. So this is the second case. Now coming to the case which you are most likely to get, or a variant of that case in your examination. That will be a shoulder impingement syndrome. What exactly is impingement? All these rotator cuffs are attached to the greater tuberosity. You know, the mnemonic sets. And sometimes it so happens, either you do too much of gym work where the muscles become hypertrophied, they tend to get trapped between these two bones, acromioclavicular joint and the humerus, and they become inflamed, or the bursa gets inflamed. As a consequence, there is a pain on movement. Or in senior age, suppose if you take an MRI arthrogram of a 50-year-old guy, you will find there is a acromioclavicular arthritis, but on palpation, there is no arthritis. Supraspinatus, initially they will say tendinosis, then 8 to 10 millimeter of tear, some fluid, slap lesion. At this age, I don't consider slap lesion. Now there are one after one tests for impingement syndrome. Painful arc syndrome, most commonly in the 80 to 60 to 120, or some might say 80 to 120 degrees in the abduction, and it is quite diagnostic of supraspinatus tendinitis. Now, what is a rotator cuff? This is one of the commonest question being asked in fellowship examination. So let's see what is this rotator cuff all about. See, we are into the glenohumeral joint. I am trying to push forward. So we have crossed the glenoid. Now what you see is on the left side is the medial glenohumeral ligament. On the right side is the subscapularis tendon, and front of it is the subcoracoid space and the rotator interval. Have a look at it closely again. So on the right side, that band you see is the subscapularis. That vertical band is the medial glenohumeral ligament. These are some fronts, and behind it is the biceps tendon. Sorry. Next test you are very keen to show is a Neer's impingement test. You hold the acromioclavicular joint and ask the patient to lift your arm by 90 degrees. Stabilize the scapula with the one hand and other hand on patient's arm below the elbow, and passively flex the shoulder forward. And again, this will cause an impingement. Let's see how it is being done. So see, first you stabilize the scapula and the patient is able to actively do it. This is a lady who is doing extremely well after we have done manipulation of the shoulder and injection into her acromioclavicular joint and also into the shoulder joint. Now, Kennedy's test. So let's go into the detail of this test rather than talking about it. So this is a very specific and sensitive test. So what we are doing is abduction and then supporting the elbow and the wrist and gently turning the arm into internal rotation. This is the area where the greater tuberosity pops up, and this is the area where the impingement test will be most sensitive. So this is the test most of the examiners would prefer if they are shoulder surgeons. Other tests are also equally good, but this is the most reproducible test, Hawkins and Kennedy's test. Now another test which we are looking for is an empty can test. So I will, rather than running through the test, I will just show you how it is being done. So this is one of our DNV student demonstrating this empty can test. Let's see it. So we have just done adduction in internal rotation, and his colleague is pressing his hand and asking him to lift up. So he has done like you're emptying the can. Can you see the position of the thumb for Nihal? It is pointing downwards. It is just like you're emptying the can. And somebody is pressing on the elbow. If there is severe pain, this means there is supraspinatus tendinitis. Conversely, you will find with just so much of pain that the patient literally drops his arm. This means there is a major rotator cuff injury. This you would expect in a young boy like him when he has got a major rotator cuff tear. Like suppose he's a fast bowler or a javelin thrower, you go into his MRI and you will find a major rotator cuff tear. I would classify major rotator cuff as more than 2 centimeter squares. Now drop arm test. Again, subluxing the humeral head, looking for a tear or weakness in the supraspinatus tendon. Examiner can hold the humerus at 90 degrees of abduction and slightly pressure to the distal forearm. If the patient arm falls to their side, this also indicates a rotator cuff dysfunction. Another test which you should know is a lift-off test. Just a minute, we'll go for it. Watch carefully. So what we are trying to do is subscapularis. We all know the job of subscapularis is adduction. So you internally rotate and ask him to extend if most probably subscapularis avulsion is from the humerus. So this lift-off test helps us to identify whether the subscapularis is intact or not. These tests are very important in somebody who is 50, 60 or 70 years of age. Now again the belly press. Now, why so many tests? Because if you normally just try to adduct the arm, the problem is that pectoralis major also comes into the play. So what you do is you slightly bring the arm forward in abduction and then ask him to press the belly. By doing this, you take off the pectoralis major and you are isolating subscapularis. Let's see how it is being done. Sorry, the slides are running, jumping up. It's not working. Watch carefully again whether the pectoralis major is becoming intact, whether both the shoulders are at the same level, and to rule out dyskinesis. As I already mentioned, acromioclavicular joint pathology and biceps tendinitis will go hand in hand. Just a revision of the basic anatomy: short head of the biceps from the coracoid process, long head from the top of the glenoid, and attaching into the biceps tuberosity over the radial. And there is a bicipital fascia also. So what are the ways? Many times examiner will be very keen to ask you, will discuss that. So poppy bulge, that is classically rupture of the tendon. Ask him to flex it and it will become more prominent. So that is the way. Again, this is a hook sign. You just ask him to extend the arm and press it from the side. This is the pathology at the distal insertion of the biceps tendon. Yergason test. Yergason test classically has been described for the subluxation of the biceps tendon from the bicipital groove. Equally, examiner might also ask you, how will you find out his biceps tendon is inflamed or not? So the things are very simple. Go and reach the lateral end of the acromion, then reach the greater tuberosity and the lesser tuberosity. In between the greater tuberosity and the lesser tuberosity, as we all know, is the bicipital groove. Palpate in that area. If you want to show the subluxation, then you go for the Yergason test. Let's see how this test is. So we drop the arm 90 degrees or more and ask to externally rotate and supinate the arm against the manual resistance and check for the subluxation of the biceps tendon from the bicipital group. This is a very characteristic Yergason test. Generally, this type of test you will find in a very senior citizen, but it can happen in anybody as well. Speed test. The examiner Akash is forcefully pressing down on the patient's arm at the forearm and he's trying to resist the power and ask the patient where the tenderness is. These tests are done to demonstrate tendinitis at the distal biceps tendon. Now, coming back to evaluation, I am afraid these are the three major cases you are likely to get in the examination. Now let's talk about impingement syndrome. Recently, I was in an examination and the candidates were showing one test after another for supraspinatus, infraspinatus, teres minor, and subscapularis. It seems that the whole discussion was blocked on impingement syndrome. But that is not the case. What an examiner will want, I was suggesting, is the biceps tendon tender, because there is definitely a logic for that. If the biceps tendon is inflamed and you do an arthroscopy and you find it is very red hot and angry, if it is a senior citizen, I would just do a biceps tenotomy. If he's a middle-aged person, I would do a biceps tenotomy and tenodesis of the biceps tendon. So every question has a logic. Then I ask them about acromoclavicular joint. This is very important. You might do a wonderful double row repair of a minor rotator cuff and the patient might come back to you again. Doctor, it is not helping. I can't sleep on that side. The moment I put my arm across my chest, I get severe shooting pain. In that case, if there is an acromoclavicular joint arthropathy, you have to excise the lateral end of the clavicle by shaver, or you will never get the full benefit of the operation. Again, look at the type of acromion. If it is a type 3 acromion, you have to shave it off. So when you are approaching an impingement syndrome patient or you are documenting the history, please mention impingement syndrome. If you classify further, whether it is supraspinatus, major rotator cuff tear, fair enough. But please note, you have to mention a note of his acromoclavicular joint, biceps tendon, type of acromion, check on the X-ray for any calcified supraspinatus tendinitis. Without that, if suppose my registrar presents a case just for double row rotator cuff and I miss out on these 2-3 important findings, the operation won't be labeled as a success, will it be? No. So now we go quickly through the examination, what exactly we are supposed to do in a classical way. So the classical way is look, feel, and move. Another thing, clinical history. Second and third decade instability, fourth and fifth decade impingement, frozen shoulder, inflammatory joint disease. Sixth onward, it's a degenerative disease. So always insist on getting an MRI, and if it is an arthritis, you should rather go for a shoulder joint replacement, resurfacing, or if the muscles are torn, a reverse shoulder. Last examination, I was very surprised. Some examiner, you have to be in the driving seat as a student. You can't let examiner examine 10 minutes of your short case just for the onset of the pain, duration of the pain, where it happens. There has to be escape route. Although it sounds very cruel, but one of the candidates, he had 10 minutes of his viva on the pain. And this is on the part of the examiner also. So be very careful. We have all discussed this. Acromoclavicular joint well localized. Don't need to tell. Thorax, like scalenus anticus syndrome, cervical rape, cervical disc, you have to rule out. You have to do a quick cervical examination or mention that his neck movements are fine. There is no tenderness on the cervical spine, no pain radiating down the arm. Night pain, glenohumeral arthritis, frozen shoulder, and most importantly, acromoclavicular joint arthritis. The patient will characteristically say that when he lies down on that side, it hurts quite a lot. Acute calcified tendinitis. Generally, we are talking about supraspinatus calcified tendinitis, or it can happen in anything. You know all the 3 stages. And when it is in the resorption phase, that time it becomes more painful. We have got an X-ray for you, so we'll discuss more later on. Instability, very important. Under 16 years of age, high chance of dislocation. Spontaneous dislocation, was it having a Morphin syndrome? Is it a habitual dislocation? And clicks are very common, as you can imagine. Stiffness, restriction of the both passive and active movements. For this, how do you define the stiffness? You look from the back and discuss the scapular disc kinesis with that. We'll talk about that later. Inspection from all the sides is an absolute must. Most probably the rotator cuff tear will be present in the front of the shoulder. It could be an enlarged bursa also. So feel underneath the acromion process and you will find a big bursa. Sometimes it is there. Biceps tendon, we have discussed at length how to identify that. What are you looking from the back? These are the congenital defaulters, spinal shoulder, Klippel-Feil syndrome, and supraspinatus infraspinatal atrophy. What I would like you to do is put both the arms above his shoulder, put both the arms again as if you're testing for serratus anterior nerve, and then ask him to hunch back his shoulder and observe carefully the medial border of the scapula, the upper border of the scapula, and see if there are any disc kinesis. Generally, disc kinesis, if you are ruled out these conditions like muscle atrophy and other, it could be because of the pain or it could be because of instability. Mostly it is a pain and the wasting of the muscle. So this is the examination from the side, and look carefully above the head of the humerus. It's a small slide. You will notice the calcified supraspinatus tendon. It is very painful. You know, there are the 3 stages, and in the 3rd stage, it becomes most painful just before the pain is about to rupture. But that is the time patient will come and insist on getting some surgery. So what you do, just put an arthroscope, you put a needle, a putty like cheese-like thing come out, you put a shaver, take it off all, don't leave anything. It is very painful. It is a chemical irritant. If it is a major rotator cuff injury, you repair the rotator cuff, but more often than not, you don't need to repair this, as a matter of fact. So again, if you're doing very well in the examiner will ask you why the lateral border is prominent. Is it LD atrophy? Superiorly, it is supraspinatus and trapezoid atrophy. It will be hunched up and vertebral. That is the prominent serratus anterior, and that is called as the beginning of the scapula. We will discuss shortly how to demonstrate later on with slides, how to demonstrate the beginning of the scapula. Palpation, tenderness, swelling, palpation of the acromoclavicular joint. We have just now discussed Paxino sign. Clavicle again, where is the old injury? What is the importance of S-shaped shape of the clavicle? Lateral end it is flat, middle end is rounded. So all these things you need to do. Subluxation of the acromoclavicular joint or sternoclavicular joint, whether traumatic because of the tumor or any other infective pathology, you need to rule out. Now the range of movements. You will find different range of movement in different things. So forward flexion up to 180 degrees, extension is 45 degrees. Please remember that. Abduction 180, adduction 45 degrees, cross body adduction. We'll show you all how to demonstrate that. So this is the way. I don't know whether you can make out in the second picture. It is a forward flexion, and in the third one, it is the abduction. You can go straight up to 180 degrees. Now, these are the different types of adduction. Second one is the cross-arm adduction. Then this is again a Dugas type of test. In cross-arm adduction, if there is acromoclavicular joint arthritis, you will get a pain. And this is the external rotation. Although I would have preferred elbow to be stuck in more tightly with the waist, but this is just to show you how the external rotation is measured. Examiner will ask you how you measure external rotation. Don't fumble. Whether you want to tuck your elbows by the side or you raise the abduction to 90 degrees and then do external rotation and internal rotation. Measure it, why you are going to do it each side, what are the benefits, what are the advantages. Some examiners could be fussy how you are measuring external rotation or internal rotation. Then Apley scratch test. The second thing is the internal rotation. Generally, I would have preferred both the elbows tucked at the back. And you can see on the right side, the scapular border has become very prominent, but this is very normal. And then go how far as your thumb can go. Generally, we can go up to the level of T3 in young patients with a very mobile joint. Now, Sometimes examiner, if you are having just pure impingement syndrome, examiner will be tempted to ask you how you test each and every muscle, or he might just ask you one major muscle. So this is the pectoralis major muscle. You can see this is the adduction, and that is why we have got so many tests to differentiate subcapsularis from pectoralis major, because you don't want to mix and match. Subcapsularis rupture is very common in senior citizen. Now this is the LD, classical LD. You know how to classify LD. And abduction. You try to do abduction of the deltoid and check whether the deltoid is contracting and how much is the power. Now this is classically to describe the winging of the scapula, the serratus anterior now involvement. You ask the patient to take a push-up against the wall. Again, trapezius, you know, has got three fibers, superior, middle, and posterior. Superior shrug, middle contract, and inferior pull down. So putting your hand, can you see the gentleman standing in front of him and trying to palpate his trapezius? Now, this is the test for rhomboid. This is a very common thing we get into the clinic, that suddenly I got a pain in the back for the last 4 weeks. And you know that just where the tattoo mark is, below that is the rhomboides minor and major connecting the scapula towards the spine, and it draws the scapula towards the spine. So either you do this test or you just ask him to straighten it out, bring it across, and palpate the tender point. You can't miss out on cervical spine unless and until examiner classically asks you, just do this test, just do that, just focus on the clinical examination for instability. It is imperative you examine the cervical spine, and I'm sure you must be by heart after listening to Agnivesh class how to examine the dermatomes and myotomes of the upper limb. Equally, what is the range of the movement? You should not miss out on the jerks and the reflexes. C5 is for the elbow flexion, C6 is the wrist extension, C7 wrist flexion and finger extension, C8 is the finger flexion, and T1 is the finger abduction. That is the intrinsic muscle we are testing about. So these are the common problems you will find into them. We have tried to identify tests according to it so that you are in a better way to present yourself in the examination. Sometimes your thought process will be disturbed, like you go with the idea of examining muscle impingement, and suddenly examiner said, oh, just do for the test for instability. Oh, just test for me the acromioclavicular joint and all the relevant tests. So you shouldn't fumble. You should have a very concrete and concise plan, and you must proceed accordingly, because that is what is going to happen in short case in 10 minutes of time. Again, this is for your benefit, because I understand that after this talk is over, this will be uploaded online. And so you need to know, like just test for rotator cuff. For me, it is the Hawkins test which matters most. If I'm worried about supraspinatus, empty can test. But you need to know all the tests, including distal biceps tendinitis. Acromioclavicular joint, please learn them, especially when you're getting slap tear, because you need to differentiate acromioclavicular joint with the slap tear. Biceps tendon, very important, examiner will ask you, because the problem is that you should not get stuck with the impingement. As I've discussed, you need to know biceps tendon. It has got a clinical significance and change in surgical practice. Acromioclavicular joint, you need to access the lateral end of the clavicle. Instability is a very different thing. So anterior apprehension, anterior posterior drawer test. We are lucky. Now the tests for instability have been reduced to just a chosen few. In my time, there were at least 25 or 50 tests for shoulder instability, and we were expected to know them. We didn't manage to do that somehow. It's the same, different tests, and you must learn them by heart, like Neer sign, arm in full flexion. You can't just lift the arm to 40 degrees. Hawkins test, forward flexion of the shoulder to 30 degrees to 90 degrees and internal rotation. That is where the impingement is most prominent. So we have just done a brief synopsis of the test, so that if you are going for the examination, please go through it. You might find it extremely helpful. Same thing, winging of the scapula, the nerve to the serratus anterior is there, commonly in the porters or in the weight lifters. So if you get a winging of the scapula, you should not feel that you have been taken for a ride. Another thing which I am not very keen to include in this are the malignancies. More often than not, they will be presented as an X-ray. But you must know about the exostosis of the shoulder. The only tumor I can think about is an EBC. You won't be getting ABC or giant cell tumor for the risk of fracturing, although they might be small. In that case, you will be only asked for the range of movement of the shoulder. And what would be most interesting would be, examiner will suddenly, if you will see by the end of the examination, by the end of the day, the examiner is tired of asking same questions again and again. So the questions tend to be skewed. So he will check for you. Have you checked for the apical lymph node in the axilla? How do you check it? What is the lymphatic drainage? What are the supraclavicular lymph nodes? What are the lymph nodes in the anterior triangle and the posterior triangle? How does a lymphatic swelling differs from the one because of the venous congestion? So if you happen to get a malignancy around the shoulder, these are the questions you should be prepared about, and a lot of other questions also. Differential diagnosis, we have solely focused on the shoulder. So we have discussed all the pathologies on the left, including the slab, Bankart lesion, and other things. Other things could be avascular necrosis of the shoulder, glenohumeral arthritis. There will be global reduction in the range of movement or pain on the global range. Neoplastic disease we have just touched upon. Thoracic outlet syndrome, scalpus anticus syndrome, referral pain from cervical radiculopathy. Very unusual, you will get cardiac cases. Aortic aneurysm, they might ask you to check for the BRU or vertebrobasilar ischemia or things like that. Diaphragm on the left side, you must mention if there is some irritation of the diaphragm, the referred pain will be to the left shoulder. Complex regional pain syndrome, like somebody has got a colitis and you forgot to ask that and you just thought it was the shoulder pain, so you should not move that. Myofascial plane and all could be in the differential diagnosis. And I think that's in all nutshell about shoulder. And this is the way I would just revise myself just before the examination. Thank you. Stop sharing. End of the slideshow. Click.
Thank you very much, sir, for this excellent lecture. If there are any questions, then maybe we can take them. Dr. Ashish is our chief interrogator. So he has been assigned this job. Dr. Ashish, you have any questions? Siddharth sir, Dhar sir.
Yeah, very nice lecture, detailed. In fact, I find shoulder examination is one of the most difficult examinations, I think. Vikram. I have a simple question. How do you differentiate between an impingement and a rotator cuff tear?
Impingement, the range of the movement will be normal. That is by the Hawkins test. And the rotator cuff tear, it again depends whether it is a minor cuff or a major cuff. Minor, I generally tend to classify as less than 2 centimeters. Major is more than 2 centimeters, and in which the range of movement will be decreased, like the empty can test.
Okay.
It's characteristic for supraspinatus. And of course, nowadays it is the MRI orthogram, which is our hallmark. We examine patient with the no-touch technique. But just by the impingement Hawkins test, if it is positive, this means there is an impingement. Empty can test or the different muscle, all the 4 muscles, we have just discussed how to say it. If there is a real range of excursion is decreased, the patient is not able to do the range of excursion, this means that muscle is lacking, whether it is supraspinatus, infraspinatus, in that particular, or the belly press of test if the subcapsularis is gone. Any other suggestions?
No, not. Shoulder is my weak point.
Yeah. See, this also happened at the last moment. If there are not questions, I might ask questions to the postgraduate student.
Yeah.
Any other questions?
So,
Okay. Yes, Rahul?
So, which is the first movement to get restricted in frozen shoulder? Is it internal rotation or external rotation?
See, Rahul, you have opened a Pandora's box. Let's start from the beginning. What is the Court's triangle, Court's classification of frozen shoulder? These are the people who have discussed frozen shoulder even before radiology. Then comes the Nevier. Nevier was of the opinion that it is the internal rotation and the inferior capsule which gets contracted. Now, the recent thing is that many surgeons won't feel shy about excising the coracoacromial ligament because that restricts the internal rotation of the shoulder. Frozen shoulder exactly is the spectrum of adhesion capsulitis, which ultimately leads to the frozen shoulder, if you know what I mean.
Yes.
So I would tend to go for internal rotation, but I know there is a big debate about IR or ER, but in real life, it doesn't work out that way.
Okay.
You got external rotation as your answer? Justify in that favor?
No, so I was like taught that way.
Yeah, that's fine. So tell me something about rotator crescent and rotator cable. You have seen rotator interval, so I won't ask you. So tell me something about rotator. This is a fellowship question.